Hello, and welcome to the Viva Vulva podcast. I am your host, Dr. Cara Quant, and I am so excited for today's podcast. This episode is all about menopause, and it is celebrating menopause because October is Menopause Awareness Month or World Menopause Month. And I feel that menopause should be celebrated. And wanted to bring on an expert in the field. She's an OBGYN, and her name is Dr. Suzanne. She's OBGYN in Beverly Hills. Just to give a little brief bio about her, she went to USC for medical school. She attended residency at Cedars-Sinai, which is the same residency that I went to. Well, different specialties, but same hospital. She's a clinical Ayurvedic specialist, which I think is absolutely fascinating, and I definitely want to dive into that. She also is a creator of Menopause Bootcamp, and she's also had many appearances on TV, including The Today Show, Dr. Oz, Dr. Drew's Life Changers, and CNN Headline News. So I am appreciative that you are giving us time to be on the Viva La Vulva podcast. But thank you, Dr. Suzanne, for coming on.
Oh, thanks for having me. I mean, when I ran into you somehow probably online, and then I saw, first of all, anybody who's got a podcast called Viva La Vulva is automatically my friend.
Yes. Yeah. And there's so many times where, like I will see other people and just seek out other people on social media. That's like the thing now, just DMing people and saying, hey, do you want to be a part of this?
Amazing people, and like had some fabulous experiences, opportunities, growth. This is what the internet was made for.
This is what the internet, yes. I mean, there's so many people that I have been able to collaborate with, both within the Los Angeles area that I did not know about, and also outside of the area, even outside of the US. So yeah, it's a great platform to connect with people that are on the same level, that want to celebrate the vulva, want to have discussions about menopause. So yes, appreciative that you're on. So wanted to dive into menopause because we are in October, Menopause Awareness Month. And I wanted to give a brief definition about it. So menopause is basically when a woman does not have her period for a year or at least a year. Exactly. That's what I was taught in medical school and in residency. And so that is the definition that we as clinicians go off of.
Correct. Exactly. Yeah. Which surprises people a lot because it's what we call a retrospective diagnosis. You don't know you're there until you're there.
Until you're there.
That is really hard for people. It's hard because the period of time between that and wherever they were in their life is very disconcerting, Yeah. It can go on for a long time. Perimenopause is what that's called.
Yeah.
And it's interesting. People's response and reaction to those words is not to celebrate and not to embrace. So I love that you started out with that. And I love talking to younger women about it because I think that having these conversations intergenerationally are critical. That's going to set us up for a more embodied experience, a more positive experience, a more authentic experience, rather than kind of running from aging, which is a thing that we do in this culture.
Yeah.
And we're both in LA. I mean, unfortunately, a lot of those stereotypes run deep, here. Maybe it's not just LA, but it's the media's portrayal of women and aging and sexuality and vulvas and all that stuff. So it's a really interesting intersection.
Yeah.
It's very uncomfortable for people. That's okay. Yeah. Apparently you and I like talking about uncomfortable things.
We do, yeah. And you know what? There's so many patients that come to me and will say, oh, just, doctor, don't get old. And I'm like, well, what else am I supposed to do? I mean, like that is the trajectory.
That's the blessing. The hope is that you do get old. I mean, I understand, it's like a joke, but it speaks volumes about our attitude toward aging. we have lost the traditional cultures, attitudes, and responses toward aging, which is about wisdom, about transmission of that wisdom, about kind of storytelling, holding the stories and the rituals of a culture. These are really important roles, and we, especially women, but men too, not as much, get sidelined, or it's the butt of a joke. You're a nag, you're a crone, not in a good way. Like it's just sad, and it just doesn't need to be that way, because the truth is that we have the power to accept that portrayal and that story or not. It's really that simple.
Yeah. It's up to
It's
us
not
to
about me
decide.
trying to look like you. Like I am not, I don't know how old you are, I'm guessing, but I am going to be, I'm 54. I'm going to be 55, and which is great. Like you said, what's the alternative? I'm not here.
Yeah. Yes,
You know,
I'm 37. I'm 37 and, or actually about to turn 37. And yeah, patients will ask me my age all the time. And I'm like,
does he look young?
I'm
Yeah,
also,
I had that too. That's a thing. In general. I think that's like a weird, they want to know that their doctor like has experience and stuff like that. And I think when you're young looking, and I'm still young looking for my age, I think,
yeah,
but now I like, look, I have gray hair. I'm clearly old. So like this doesn't happen to me anymore, but it happened for the first 15 years, 20 years. Well, I'm 20 years in. I mean, honestly, I think when I stopped coloring my hair 2 years ago, then that stuff sort of stopped. But people want to know that they can have confidence in you. And so that's ironic, right? If you're old enough to be their doctor, but not so old that you're like a gross old lady.
yeah. Yeah, this age thing, ageism, all of it does run deep, especially within the LA. Yeah, we're near the media, we're near Hollywood, all of those things. So
Yeah.
I understand.
Yeah.
And I don't take it personally. I have come to accept, like, I'm just not going to take it personally, that, like, I know what I know, and I've, gotten a good education, and like, that's what it is.
Yeah. Yeah. But you're right. That happens. That happens.
It does, yes.
Mm-hmm.
But
Yeah.
getting to menopause, so like, what happens, Dr. Suzanne? What happens hormonally when women reach menopause?
Well, what happens hormonally is that things finally kind of peter out. And what's happening in that period of time called perimenopause that I was referring to, and what makes it so uncomfortable, is in order to understand that, we have to understand what was happening before. Okay, so during our reproductive years, during the years that we are menstruating on a regular basis, that whole hormonal process is very complicated, and it involves shifting hormones that are signaling. So brain signaling hormones are coming from primarily the anterior pituitary gland. The hypothalamus is a small gland in your brain that's talking to a lot of the hormonal glands in your body, but specifically with regard to this, it's talking to your ovaries. And so they have a very complicated relationship where the brain is signaling the ovary to choose an area called a follicle to develop and to mature. It's creating all sorts of hormonal changes. Estrogen is going up. And then eventually, about halfway through your menstrual cycle, and when we as gynecologists, doctors talk about the menstrual cycle, we're not talking about the days you bleed, we're talking about the whole event. Mm-hmm. It's an interval, it's episodic, right? So it's every 28 to 30 days on average. Around midway through, finally, the ovary will release one egg, okay? And then the hormones shift into more progesterone dominant. In the case that you do conceive, then there's a nice fluffy endometrium, the lining of your uterus, that's been built up by this estrogen. You've got some time for that to happen. If it doesn't happen, everything starts to decline. So you have a wave of hormones. It's not quite that simple, but that's it. Anybody who took even high school biology got that wave, right? You see the up and then the down. That's what's going on with the hormones. And it's going on fairly predictably month to month. And women live in our bodies. We really live, honestly, very much around that cycle. We know who we are, what we are, how we feel in our bodies, how our thoughts are, what we want to do, our energy level, our sexual energy, our creativity. It really, whether or not we're really totally aware, some people, I think more and more there's a lot of conversation about this and people are aware and they really are really embodying that and embracing it. But even those of us who don't know it, it's happening. You're more talkative, you're more bold in the first half of the cycle, you're more quiet, you're more relaxed, you're more fatigued in the second half of the cycle, and then you bleed. Okay. And then the whole thing starts over. Well, in perimenopause, which could be 2 to 10 years, could be 15 years, things start to get a little erratic. They're not as predictable. Maybe you don't ovulate 1 month. Maybe it takes 40 days to have another cycle. Maybe they're closer together. Maybe your cycles are more painful. Maybe they're more heavy. Maybe the premenstrual symptoms that you had shift or intensify. Finally, you start to skip until you skip and skip and skip and it stops. So that smooth wave of hormones that you were getting before is no longer. It's really not true that you have zero estrogen, excuse me, but it's a very, very low at that point. So the signaling hormones go up because they're like, first they used to whisper and the ovary did its job. Then it's sort of like, hey, you. And then it's screaming and nobody's listening. The ovary has gone to sleep. The ovary has left the building. So you do still have hormones, and then you have no hormones. And, other glands like our adrenal glands are also responsible for things like androgens, which people call male hormones. They're not male hormones. Women actually have more testosterone, but whatever. That's another podcast.
Yeah.
Hormones are complicated. People don't understand hormones too well. Sorry, let me turn this off. So, and fat is a location where estrogen is produced. So people who have more fat on their body will continue to do what we call peripheral conversion from the basic steroid hormones, cholesterol. That's why fat is actually really important in your diet. Because if you don't have fat in your diet, good high quality fat, you're not going to make your hormones. So the thing that changes is that pattern no longer exists. And again, like I said, because we identify so strongly with that pattern, that becomes disconcerting. And then also because the predictability of the symptoms that we feel goes away or changes, that is very disconcerting. Yeah. On top of it, you start feeling different things. Your body tissue changes. Your collagen is lower. You have more dryness, not just vaginally like people talk about with sex, but just your skin in general. That's where wrinkles will come in, from dryness and collagen loss. Your energy level may change. Your metabolism may change. Obviously, the classic hot flash symptom may be occurring for you. So, there are a whole host of both superficial and deep changes that occur. Your body changes. Your health can change if you're not paying attention and watching out for those things. So that's kind of some of the consequences of hormones. Hormones are chemical messengers. That's all they are. They're the way your body talks to different parts and pieces, because we are an integrated whole. We like to think of ourselves as like, you're a primary care doc, so you take care of these 5 organ systems. Yeah. And I'm a gynecologist, so I take care of that organ system. But that's silly. That's not how this works.
Yeah. And I completely agree. And I think that there's times where as internal medicine doctor, and even like during training, I remember not getting that much training on women's health. And it's like, but I'm still seeing women, and I'm still, occasionally doing pap smears, and I'm still having discussions about menopause. And so I need to know this information from a primary care internal medicine standpoint.
Well, that's a really great topic that you bring up, because the truth is that actually in OBGYN residencies, so that's the specialty that is taking care of women, the evidence is very strong and clear that menopause education is abysmal. People come out of residency, a 4-year residency, not feeling confident, not answering questions right, not knowing how to take care of a menopausal woman. I mean, there's lots of data out there about that. There's a lot of reasons, and that's not what this podcast is about. I mean, shoving 4 years of women's health is, that's hard. And it's a surgical specialty. We do surgery. So we end up concentrating a lot on the stuff that's like real high stakes. But the thing is that a third to a half of your life in North America is going to be spent in menopause. That's a lot of folks. So that's one of the reasons that I've been so on this, because we are not appropriately addressing this hugely important phase of life. It's a physiologic event. It's not a disease.
Yeah.
And like I said, like the average age of menopause is 51.4, because this is how we roll in medicine,
Yeah.
51.4. That's the average lifespan of a North American woman is like 80. Okay, so do that math. A lot of years that we're not really sure what the hell we're supposed to be doing.
Wow.
Mm-hmm.
Oh, yeah, and I mean, I haven't, just getting to that point, I haven't had a conversation with my mom about menopause. I know what she's going through. I know, the times where she gets hot flashes and she starts fanning herself. She needs to get to someplace cool, a fan. But we haven't had, like a formal conversation about menopause. I mean, it was the same for periods. I mean, I had like a little conversation, but it is helpful to have this conversation from the medical standpoint, but also just giving information to women, mothers to their daughters, or
Yeah.
mothers to other women, just
Mm-hmm.
talking about menopause, because yes, it's inevitable and we're all going to go through it, and it's not
Yeah.
a shameful thing that
Exactly.
happens.
Exactly. And it doesn't have to be so anxiety provoking. I mean, nobody wants to hear that they're going to be uncomfortable and they're going to have a hot flash, okay, or that their sleep will change, or they may get more belly fat, or all that. But that's not, we don't need to boil it down to all the negatives. I think people are understandably going to be anxious and afraid of something that they don't know anything about.
Yeah.
So all we have to do is talk about it. I mean, when I started doing these menopause boot camps, it was so interesting to me because I did it because I just couldn't possibly get the information across in a 5-minute visit or a 20-minute visit, because I'm running late because you need to talk, which I do all the time. And people were really thirsty. Like, and when I'd give a talk about anything, if there was anything menopause-ish, like all the questions would be about that. People would be surrounding me afterwards, which was great. And I realized, okay, there's a lot of content that just people need to have.
Yeah.
I don't even know why this didn't occur to me, but what really ended up happening was destigmatizing the word, because that literally, people would come in and say, oh yeah, I told my husband I'm going to the yoga studio. Like they didn't want to say menopause. And at the end, they were like, I'm menopause. But at the end of one series, one woman actually said to me, yeah, could you just like change the name? I was like, no. I think you need to do some more work, and I'm happy to support. But no, I'm not
Yeah.
changing the name. It was wild. But so that was number one, destigmatizing the word. So simple. And number two, community. Community. We need to be in community. We need to experience things together as a group. It's why this pandemic has been so painful for people. Even people who are like, I'm an introvert, this is my best life. People need each other to reflect off of each other, to validate, to tell the stories, to hear the information, to feel not alone.
Yeah.
And that was the most powerful thing that happened, which I don't even understand myself, because I'm always touting that. I don't know why I didn't anticipate that, but it was awesome. And that's what built it.
Anticipating the boot camp.
How important the community building aspect
Oh, yeah.
because in the end, I feel like that was maybe the most important thing that happened. It really wasn't even the information.
Yeah. Yeah. Oh, yeah. Definitely. Yeah. Building community, knowing other people are out there going through the same thing,
Yep.
or it's going to happen eventually.
Yep.
And these are
Yep.
the symptoms to watch out
Yep.
for. So going over the symptoms that we talked about, the hot flashes, mood swings, sleep disturbances, is that inevitable for all women? Do some people not go through menopause, or not
Yeah,
have
not
the same
it's
intensity of
not
symptoms?
it's not inevitable, but it is the most common. I mean, like 80% of women are going to have hot flashes. They just are. Now, that doesn't mean they're going to be severe. I think a lot of people, my observation and my own experience has been that it's for most people, it's not severe and debilitating. There's a percentage that it is, and there's also a percentage that it goes on for like a decade or more. There's data on like, I don't know, something like 5% of women over 70 will still have an occasional hot flash. I'm not talking like they're up all night and they can't sleep, but
Yeah.
they still have a hot flash. So, and I think we don't really even understand what a hot flash is. It's something to do with our thermoregulatory center in our brain. It's not really exactly well understood. So it's not inevitable, but these are the things that you mentioned are the most common events, and most people will have them at some point, and most people will be able to handle them. I mean, and the thing is that there's plenty of things that can be done to help people get through that, you
Yeah.
know?
And I mean, that brings me to my next question of like, what are some things that women can use or do or take that is going to help their symptoms lessen?
Yeah. So, I mean, of course, it depends on what the person's medical history is,
Yeah.
and what their values are and their priorities and their goals. And a lot of times with my patients, specifically with this, I really try to do some goal setting with them, because I think if we come into the encounter thinking, oh, she's having these symptoms, so we're going to do X, Y, X, that's not addressing what her issue is. Her issue may be, look, I'm not sleeping and I have a terrible mood. My hot flashes are causing those problems. The problem is the downstream effect. So that helps me kind of look at what's going on, and really understand where she wants to get, where she is and where she wants to get. I mean, I think that's just good advice in general, but I find it's like really, really obvious. It's become more obvious with time that needs to be the approach with menopause. Again, because it's a physiologic experience, it's not a disease.
Yeah.
So what can you do? Everything from hormone replacement therapy, which is a very, very nuanced, very nuanced. There's not one way to do it. The data is all over the place. I think people have and I brought it up first because it's pharmaceutical and we're doctors, and also because people get really freaked out about hormones. And I just want to say, like, have a conversation with someone who is not just trying to sell you stuff and knows what they're talking about. So
Yeah.
that narrows the field. I'm not going to lie. We're out there, but there's not tons of us. But hormones are not necessarily evil. Okay, so that's one way to deal with some of these things. There are a lot of amazing herbal remedies out there. They are never going to be evidence-based in the way that a pharmaceutical will. They're just not going to, because nobody's going to benefit cash wise. That's how I just had this conversation with my IG live that I just did with another doctor. Non-medical people don't understand research. Research is important. We need to have evidence. I would like to only do things evidence-based, but research is happening because a pharmaceutical company is going to make a lot of money. So
Yeah.
they're not going to make money on it. They're not going to do it. So when you see, and that when our colleagues crap on a herbal study because it has 70 people and it lacks power, I mean, that's true, but pharma is not going to make money on it, so they're not going to look at it. So that's not really totally fair.
Mm-hmm.
But I'm just honest with my patients about what the evidence is and what it is not. But there are a lot of amazing herbs out there, many of which are safe. Now, herbs are medicine. And I think for people to use herbal remedies, they really should be working with somebody who has integrative background, who has a background in holistic medicine, like for real, not like I did a weekend course.
Yeah.
Like Chinese medicine and acupuncture. Ayurveda can be a little iffy because not all of us are certified, and it's not regulated by the states or by the federal government. And
Yeah.
that's a whole controversy in and of itself, because a lot of my colleagues don't want that. They want to maintain the guru tradition. There are benefits and problems, disadvantages with that approach. Ayurveda does things very differently, but there are a lot of amazing just body treatments, a lot of relaxation techniques that are considered cooling. And because you're having, let's say, hot flashes, they really can be a benefit. I think probably the impact on the mind-body connection and neurotransmitters is really where that's coming from. There's some really interesting studies on a traditional technique called Shirodara. You lay, and usually an herbal infused stream of oil is actually poured on your third eye. Okay. But there are documented physiologic benefits, probably because of the neurotransmitter impact and maybe on the cranial nerves. But there's a what happens is your parasympathetic, your relaxation response increases.
Yeah.
And been shown, I mean, these are Indian studies, but there's a really crazy, I'll try to find it and send it to you, really crazy study where they really looked, not crazy, it's amazing. They looked at menopausal women, and they looked at like hormone replacement therapy, like Shirodara and other like Ayurvedic body work, and then like a combination of herbs and the body work stuff. And the people who did the Ayurvedic treatments really benefited.
Wow.
They really benefit, like their hot flashes were decreased. Their moods were better. They were less anxious.
Yeah.
So, you know, that's highly specialized. And then I think just good old fashioned sleep hygiene, exercise. And you don't have to like go do, you know, start doing boot camp. I
Yeah.
mean, if you're doing nothing and you start to walk, something, those are really, really important. Get the blood flowing. It's going to help your cognition. It's going to help your mood. It's going to help your sleep. It's going to help. The blood flows everywhere, including the genitals. Okay. It's going to help your sex life.
Yeah.
So it's obviously going to help your heart and your bones. So some of it's, you know, there's sort of from one end to the other. There's lots of things you can do.
Yeah. You know, I actually have it's a very specific question, but you talked earlier about how you know, fat in our body produces estrogen. And so like for women who are obese, are their symptoms not as like, do they not have as many hot flashes as a woman that has normal BMI?
Not always. That's a great question. It's not always correlated to hot flashes, but we do know that women who are obese do produce more estrogen. And in fact, that is a risk factor to developing cancer of the lining of the uterus.
Yeah.
Because they're getting a lot more, and it's not just estrogen, it's the type of estrogen that's being produced. Because there isn't just, of course, why would there be one? There isn't just one kind of estrogen, and some estrogens are more cancer producing. They do increase risk of breast cancer. They do increase risk of cancer of the lining of the uterus. So that's a great question. I don't think there's data supporting that.
Yeah.
Because again, it's not just the deficiency of estrogen that causes the hot flash. Remember, it's the thermoregulatory center. The declining estrogen and the increasing FSH, which is that hormone I was talking about that comes from the brain, those are signs of impending or menopause itself. They're not necessarily correlated. And this is, thank you for bringing this up, because I get your best friend, your Pilates instructor, your nutritionist, your neighbor, all told you must have your hormones checked.
Yes. Yeah. And there's some women that will come to
your nutritionist also. Oh my God. I'm sorry. My assistant's calling me, not realizing I'm doing this. Anyways, so everybody's telling you to get your hormones checked. And I'm not saying don't get your hormones checked, but the thing that people fail to understand is that, first of all, we're not going to probably treat you based on your hormones. There are people who do that, but again, that's not evidence-based.
Yeah.
And second of all, it's not meaningful. It's not clinically significant. If your FSH is above here, it's not like, oh, you're going to have a hot flash. But if your estrogen's there, your mood's going to be shit. Nope. Not correlated. So you got to treat clinically.
Yeah. Yeah.
Based on the person's goals.
I see. Okay. And I was saying that to go off of the recommendation or the treatment, I guess you can say, of, you know, exercising. If someone is like, oh, well, I'm bigger, so I have more estrogen, but that's not the case, because there's different estrogens in the body, and so it is helpful.
But exercise has been shown to decrease hot flashes. Even just moderate exercise. Again, you don't have to be like going crazy. You don't have to be a fitness model.
Yeah.
You move.
Just move your body. Move your body. Okay. So what are some, as an OBGYN and women coming to you about menopause, treatment of menopause, what are some common misconceptions about menopause that we have, if we haven't hit anything?
Well, I mean, I think a lot of the stuff that we've talked about, which is like a fear that like, this is it, it's over, this is the end of everything for me, that you're drying up and blowing away. That if you have, for instance, a family history of cancer, or if you yourself have high blood pressure, that there's nothing that can be done, or you have a personal history. I have a history of breast cancer. There are certain things I don't do, but there are many things available to me. Yeah. So that's, I think, a big conception. I can't because, you know, that's, well, okay, again, what is it that you're looking for? Okay, here is the wide variety of options available. So I think those are the big misconceptions that I think I hear the most. And I think sexuality, I mean, look, you and I could do a whole podcast on sexuality in menopause, and I think maybe we should, because I think
we should, yeah.
I think that obviously there's plenty of people out there talking about sex in an older life and how great it can be. Is it different? Of course it's different. You just got to roll with it. You got to work with it. But, it can be the best of your life. You're not going to get pregnant. That's awesome. You know what I mean? And you can be, and I think people frequently, if they've done the work, are much more comfortable in their own skin. So it can, it's not true that like it's done. If you don't want to have sex, I don't care. That's cool. That's fine. I'm not here to tell you you must have sex.
Yeah.
But I think if you've given up on it because you think you can't, or it hurts so much and you didn't know there's anything you could do. I mean, there's things you can do, and it's not just one thing. And if that didn't work, you're done. Oh my God. There's everything from hormones to better lubes to CO2 lasers to, I just found a new thing, carboxy gel, which is like this gel that couldn't be bad for anybody, and it basically increases oxygenation to the tissue. There's so many things.
There's so many things that are out there. And I was going to ask that, like what happens to the vulva and the vagina after menopause, but it's a common thing with vaginal dryness and kind of the atrophy of the tissue.
Right. Yes. So the tissue really does change. And the vulva specifically, like we talked about, and you're getting collagen loss and fluid loss and less blood flow. So the tissue does change. It shrinks back. It flattens. It's not as fluffy. Some people are really upset about how their body looks different. And, I get it. And I think that's a process people have to work through. If they feel really strongly about it, there are things that can be done to change its look. I think I'd be very careful about doing that. I think how it feels is more important, but but vaginally, same thing. The vaginal lining is much like the lining of your mouth, the mucosa. It needs to stay moist, and it can get very thin, very fragile, very delicate. And it's not a matter of just putting lube in there, because the tissue itself used to be able to expand. So this is the analogy that my really dear friend, who's one of my mentors, and he's a sexual medicine guru. He's fantastic. And he talks about how the vagina under the influence of estrogen is like an accordion. It can distend and go different directions. And look, if a baby could come out of there, a penis can go in there, all sorts of stuff can happen, when there's no influence for a very long time, it's like a PVC pipe. So it's not just that the tissue is delicate, it's that it's stiff and non-distensible. So that's a problem for somebody who wants to have penetrative intercourse.
Yeah.
But even just the clitoris and the urethra, I have a lot of patients who keep thinking they're having bladder infections. They're not having a bladder infection. That tissue is also dry and irritated. So this is why it's so important to really understand your anatomy, so that you can assess, like, okay, I'm feeling this way. What could it be? How am I getting help? So yeah, cosmetically it'll change, but in terms of feeling, there's lots of stuff we can do. Like, I've already mentioned a lot of things that you can do.
Yeah.
And it's important to stay healthy,
Yeah. And I think that from my generation, or like the 20, 30-year-old standpoint, when women do think that sex is going to stop at menopause. And I have seen many patients who sex has continued, or they wanted to continue and are asking me for, like tips or, other medication or just things that they can do.
Right.
And yes, there is a lot out there that can be done. There's lube, there's vaginal moisturizers, there's hormones that you were talking about. There's a lot of things that women can have to make their sex life still continue and still be very pleasurable.
100%. And just being creative, being creative in your approach to pleasure, but if you have not felt comfortable in exploring your own sensations and your own pleasure, then it's never too late to do so. But it's definitely going to be, it's like a whole other thing, because now you're going to unwind all of that. And that's okay, because for a lot of women, this is an age where we have the time to do that. You know what I mean? Like, I don't know. My generation, just speaking broadly, was raised really differently around sex. Like people, even I think early in my career here, I found myself like Sexual health is another area that we don't get information on. And I had to really learn. I had to like find the ways to learn. But even early on, I was like, oh my God, these people are talking about sex so much to me. I don't know, what do I do? You know? 20 years in, I'm like, bring it. You think you're going to shock me? Because I seriously doubt it. And if you do, I'll never tell you. Very good actor. Because no one would ever tell me anything otherwise. If you look at, oh, what? So and I learn a lot from my patients. But the thing is, like, it's a lot because it isn't just the body. It's not a body part. It represents so many different things.
Yeah, it does. I've learned a lot from my patients, and it's funny that patients would be like, "Oh, this is so embarrassing," and it's like I've heard a lot. Like, believe me, I've heard a lot, I've seen a lot. So
I mean, I think it's easier for me to make the joke because I'm like, I'm a gynecologist. Seriously, like, you're not going to scare me, gross me out, or shock me. So for me, that joke is spoken so many times a day. It's okay. People are vulnerable with us.
Yeah, it's a special, it's a privilege that we
really
have.
is.
It's definitely a privilege.
It really is.
Yeah. And I'm honored to have patients tell me, secrets and things that they've never told other people before, just so there can be a solution or like some movement forward of whatever they're coming in for. So so I want to, as it's coming to an end, I wanted to ask you a question that I generally will ask my guests on the Viva La Vulva podcast. But because it's called Viva La Vulva, I wanted to have you give the listeners an uplifting story or just a fact about the vulva.
Oh, yeah. Okay. So, there's so many things. I mean, I think probably I'm not going to be the only person to say this, but the idea of the vulva having like some particular look is just not real. And there's so many great art pieces out there and posters and like pictures. I've seen artists who do like vulvar impressions just to show the great variety of like how somebody has really long labia, somebody's, vulva are really puffy. And I think just understanding the beautiful uniqueness, just like our faces and our hands and the rest of our bodies, like that goes such a long way to embracing our uniqueness and beauty. And that's going to continue to happen. Like the way your vulva looks when you're 7 isn't going to be the way your vulva looks when you're 17 or when you're 47 or when you're 77. And that's cool. Like that, I wish people would know that and really believe that. I think that's more than enough to say about it.
No, I love that. And I look down upon, or I just frown on the industry of like vulvoplasty or, just doing some reconstruction.
The term rejuvenation is offensive to me. And I do surgeries because look, I have had people who have labia that are ripping with their underwear. I mean, they can't play sports. It hurts when they have sex. Like there's a reason to do some of these procedures. And I'm not going to judge. People are allowed to make their decisions and we're allowed to decide if we want to participate. However, having said that, calling it rejuvenation is gross. It's misogynist. I don't need to explain that to you.
I don't agree with it, but and I love the fact that all vulvas are different and special and unique.
Yes, I mean it sounds like if Mr. Rogers were to talk about vulva.
That's what he would say.
Yes, he would definitely say that. I feel like he might have said it and they were like, too soon.
I like that. Well, Dr. Suzanne, I thank you for, again, being on the podcast and talking about menopause and hopefully giving the listeners some uplifting information, or I believe we have given some uplifting information about menopause. And it's not something to be, looked down upon, but something to be celebrated. There's different things that we can do to help enhance or just help the experience of menopause. So I appreciate you coming on, and I wanted to have you give the listeners a way to keep in contact with you, social media, website.
Yeah, I'm pretty active. I'm actually very active on Instagram mostly. I'm on Facebook also and Twitter sometimes, but my Instagram is at Ask Dr. Suzanne, and that's AskDrSuzanne. And they can also go to my website because a lot of my stuff lives there. So that's the Dr. Suzanne, TheDrSuzanne. Can sign up for my email list. You can find out when I'm going to get to do a Menopause Bootcamp again, which I'm hoping will happen in 2021. See my media, read my articles, connect with me. Yeah, I would love to talk to whoever wants to talk.
Okay.
I'm really appreciative of you having me on, Cara.
Thank you. I will put your information in the description. So if you guys didn't get it, it'll be in the description of the podcast. And with that being said, thank you again. And thank you, listeners out there, for listening to the Viva Vulva podcast. If you enjoy what you're listening to, please subscribe. Please tell your friends and family about the podcast so that we can continue creating podcasts and different content. So with that being said, bye.